Good morning, everyone, and welcome to this great session. I really appreciated David's comments. Number one, I learned an awful lot. Number two, what he had to say is not totally inconsistent with what I'm going to say this morning. And number three, very importantly, I learned that a petabyte isn't a dog biscuit. So, you know, you learn something new every day, which is really great. It really is a time of change out there. The landscape of health data is really evolving. It's really changing. And it's moving very quickly. And I really do think that big data analytics, or BDA I'm going to call it for the remainder of the morning, is going to be an essential part of that evolution. At Ki-Hi, I really have the best job in the country. I get to collect data, I get to clean data, I get to push data out there, I get to educate people about data, and we get to transform data ultimately into knowledge. It really is a great job. So before I talk to you more about a BDA and where I think it will fit in within the Canadian healthcare sector, let me just do a little bit and tell you a little bit about Ki-Hi first and foremost. So our vision at Ki-Hi is pretty straightforward: better data, better decisions, ultimately leading to healthier Canadians. We were created in 1994, so next year is our 20th anniversary. And we're funded by the federal government, about 80%, and by the provinces and territories, about 20%. One of the interesting things about our place is we're about 60-65% female, including in senior leadership. The guys are outnumbered. And they're incredibly smart people, about 700, just fabulous and very, very, very talented individuals. We have 4 lines of business, and the first is really data. We maintain on behalf of Canadians 28 databases and registries, which covers the whole gamut in the healthcare system. That data is provided by hospitals, clinicians, regional health authorities, provincial ministries, professional associations, and residential facilities. We store the data in a privacy-sensitive manner, and that's super important for us. And we are considered one of the platinum holders of privacy. There's 4 of us in the country out of Ontario here. And so we're among the best of the best when it comes to both privacy and information security. The second area is our standards, and really that's at the core of who we are and what we do. Part of our job is to make sure that not only is the data quality of a high quality, but also that it's very reliable, that it's consistent, comparable, and accurate. And we maintain Canadian standards in a variety of areas, including that for the electronic medical record, classifications and coding. We maintain standards for case mix and also the inter-eye instruments. The third area is analysis, where we get to turn that data into actionable information. We have a 2-year rolling analytical plan, and currently we have over 32 projects underway or planned over the next 2 years. And finally, the fourth area, and I'm going to talk a little bit more about that because it's really important not only for what we do, but also for BDA at the end of the day. It's about understanding and use. We view capacity building and educational tools as fundamentally important to being able to utilize that data. Last year we produced 181 self-study courses. We delivered 127 web conferences, 67 workshops, and we had almost 25,000 participants in our educational opportunities out there. So what about big data? So when I was invited to speak at this session, I knew a little bit about big data, and I consulted the wisest person in the world, one of my sons. He's got he thinks he's the wisest person in the world. He's got a graduate degree in software engineering, and he thinks he knows everything. I'm sure he does. We actually spent a little bit of time this summer where we traveled from Santa Monica up Highway number 1 up to San Francisco, and he beaked at me the whole way about BDA and what it can do for you and so on. So not only talking with him, but I've also taken the opportunity to talk with a lot of other folks about big data analytics. So I think you're all familiar with the Gartner hype cycle, and boy, oh boy, the hype is just awesome out there, right? It's just terrific. You know, it's all captured here quite nicely. And a couple of things I just want to point out is you can see where big data is. Natural language processing is just a little bit behind it, right? And then out on that plateau of productivity, we have very importantly predictive analytics, which I think is wonderful. So the hype is great. The jargon, the jargon's amazing. It's just awesome as well, okay? I've never heard the word or seen the word insight used so many times in the last year as I have in all my life, okay? It's everywhere. I'm sitting on an airplane. Character has a big data analytics book beside him, you know, and the word insight is splashed across it. It is fun, okay, and I mean it in a fun way. But in terms of the jargon, I must say, I also, in terms of trying to educate myself, spend an awful lot of time trying to understand the nuances associated with a lot of the words that are used in describing big data analytics. Tongue-in-cheek, I learned that if you put a data scientist and an IT specialist together and ask them to come up with a definition for big data analytics, you'll get 5 different interpretations. And they'll go on to tell you that big data analytics can provide you answers to questions you didn't even have, and as well, it can cure lumbago and bad breath. But I also learned that big data analytics is grounded in the math that I took as an economist many, many years ago, about 40 years ago at university. Econometrics, statistics, operations research, queuing theory. But that it really has grown to encompass new areas, such as artificial intelligence, and we'll come back to that later as well. All kidding aside, it really is a bit of a confusing and a difficult world out there, where definitions do differ. The value proposition really isn't well defined as of yet, and some claims are pretty interesting, some aren't. There is, however, some common defining characteristics to big data, and I think David went over these, and just in a slightly different way. Again, to remind you, volume and lots of it, very important. Secondly, the velocity, it's got to move fast, in real time or near real time. Thirdly, variety, new and different sources that are out there and formats that can be integrated, and that's an important word, integrated. And finally, I also learned that some other people add a couple of other V's that are out there, veracity, I should say, and veracity really is about the truthfulness of the data, or really the quality or the reliability of the data, and others add that other V called value. When we think about CIHI's databases, we certainly do meet the volume criteria, and these are just 3 of the databases that we have out there. Our drug plan data, we have about 1 billion records on file, and each one has about 43 fields. We're bringing them in at about 250 million additional files a year, and we anticipate that ramping up even further as we expand our drug plan data. Our home care data is only about 10 million records so far, but recognize that there's 500 fields per record, so it's a fair amount of data that's there. And our long-term care data, which is very substantive as well, again, only about 4 million records right now, but it is ramping up and there's an awful lot of fields associated with that data. So the volume's there. Unfortunately, with the holdings at CIHI, the variety is there to a certain degree, but what really is missing is the velocity. We receive our data monthly, quarterly, or annually. We don't get it in real time. We'd like to, and that's where big data analytics may just fit into the future. Let me move on to something that characterizes data across the spectrum in healthcare, and there really are 5 areas. The first is the care to the patient. And that's really where an awful lot of big data analytics is going to be found into the future. And that's the clinician interface with the patient. That's the implementation of the electronic health record in Humber River or the mainland, lower mainland experiment in BC. That's where a lot of data is going to be flowing in real time or near real time. Where do we focus, though, at CIHI? We focus in on what we call the health system use of information, which are the 4 other categories, from clinical management through to health system management, public health, and research. But one of the key things that I found in my discussions around big data analytics with folks is there's a lot of commonality to the issues in terms of the primary source of data or the primary use of data in care to the patient and secondary uses of data. Way back when, in the olden days, 2008, the health deputy ministers in this country asked CIHI and Infoway to co-lead a little bit of an initiative to, quote, make sure that Canada was ready to seize the opportunities associated with new data from new electronic sources, unquote. Simply put, information increases system performance and the quality of care received by patients. Recognizing that, the deputy ministers were very interested in making sure that it's not only captured, but that it's utilized quite effectively out there. Together with Infoway, we put together a little bit of a vision paper for the deputy ministers, and in 2010, they had a look at it and they said, yeah, that's good, but we need some refinements to it. So over the last couple of years, we've been working hard to refine it, and we had discussions with about 125 healthcare leaders across the country on the vision paper and refining it and articulating it in a clearer sense. As a consequence, this last June, we went to what they call the Conference of the Deputy Ministers and presented the revised paper, and that was signed off by the deputies. There really are a number of building blocks to this, really 3 key building blocks to our vision paper. And again, it's not only for health system use, but I think it's really applicable to big data analytics. The first are down at the bottom, and those are called the enablers. Having a good governance framework in place, having the policies and technology in place is extremely important. And when I say policies, it's not just privacy policies, but it's also information security policies. You need to keep that data private, and you need to keep it secure. Now, when you look at these foundations, they're straightforward. Well, they're anything but straightforward. We employed the Newfoundland Centre for Health Information on a proof of concept project. We asked them to go out there and see if you can unite a few different databases, including data from the EHR and data from the EMR, and tell us what the issues are and what you found. And what they found is that governance is a huge issue, particularly when the data is owned by different groups. And people have a tendency in healthcare of saying, it's my data, you can't have it. And that's a huge hurdle. So while data may stream off of sensors and other technology tools into the future, making sure that there's a really solid governance framework along with privacy is extremely important. The complexities of linking this data is very, very troublesome from time to time because some of it is simply not structured, okay? And making those linkages can be problematic. And again, that's what the Newfoundland Centre found. Secondly, to all of this, you can see is the data, and it's the analysis and use. Simply having the data available is one thing, but the data really in our world, or in CIHI's world, must be accurate, making sure that it actually reflects what it is intended to measure. It has to be reliable in the sense that it can be trusted, again, that word back there of veracity. It has to be timely in the sense of it's got to be available for its intended use. And finally, it's got to be comparable, so it can be standardized and aggregated or linked with other data. One of the things I was reading is that they're saying that 80% of healthcare data in the year 2015 will be unstructured data. This is a bit of a problem, okay? Unstructured data is what you find in most of the EMRs here in Canada isn't all that helpful. And let me try to explain what I mean by that. Back in 2009 at CIHI, we undertook something called the VRS project, or the Voluntary Registry System. And we went out and we asked clinicians, would you please sign up with your EMR, because we want to extract your data, and what we're going to do for you is spew it back to you, let you know what your practice looks like, how your practice stacks up against other Canadian practices, the type of patients you have, the interfaces with the patients, and so on. So since 2009, we've lined up with 350 clinicians. I want to point out that there's about 37,000 family practitioners in Canada, and we managed to hook 350, that's all. But it does represent about 400,000 patients. And so we are looking at potentially a landmine of data, a gold mine, sorry, not a landmine, a gold mine. Whoa, it is Wednesday in Toronto. But a gold mine of data. It's good to see some of you are still awake. That's encouraging. What we did find, though, is that the unstructured and non-standardized data really doesn't support sustainable quality source of primary health care information for analytical purposes. We spent endless hours, endless amount of time cleaning the data, trying to put it into formats that make sense. I appreciate that some university profs talk to us about algorithms that could be developed and a variety of other things, but the cost of doing so and the return on what's available just simply doesn't make the data in our EMRs here in Canada of great value, okay, at this point in time. The use of pretext out there is a great thing, but there are over 200 ways of describing, one's smoking status. And trying to collate all of that and make sense out of it is extremely difficult. So as a consequence, and unfortunately, we are going to be closing our project, that voluntary registry system project. And we're going to thank the 350 physicians for the data, but we're simply going to say, guys, it's unstructured, it's not coded, there's a problem here, and when some government steps up to the plate, or you step up to the plate and say, hey, look, it's got to be structured, it's got to be coded, it's got to look like this, then we're just going to step back. So we are going to continue on standards, national standards for primary health care, and we are going to continue on analytical work in the primary health care field, largely through the databases that we have around physicians, fee for service. But when it comes to the EMR, it's just not on, at least for us. Another example of data analysis and use, and I just want to touch on this one, is I was talking with a few folks earlier about diagnostic imaging. And PACS has done a wonderful, wonderful thing in each and every institution that they've been implemented. The problem, though, again, is that there's no structure to the data. A lot of it's pretext, and there's some issues. Some of the problems with this were made clear in a report by Dr. Doug Cochran. Doug was taking a look at radiology problems in British Columbia and trying to come up with a way to make sure that the quality was much higher than what they were dealing with. But in obvious frustration, he wrote, and I quote, "It was impossible to review obstetrical ultrasound images retrospectively because a standardized approach for image recording and reporting was not taken for each examination." He went on to say, though, that Vancouver Coastal Health Authority had a real problem because clinicians couldn't share PACS data from one system to another because it wasn't standardized. So while we have great systems in place around diagnostic imaging, the systems don't talk to one another. And, nationally, we don't have a data source for diagnostic imaging. And provincially, a lot of the provinces simply don't. And it's one of the fastest growing areas of expenditures in all of the country. We need standardized and coded data. There is such a thing as bad data out there. I know some people say, no, there's always some use that you can get out of data. Well, not always, okay? Natural language processing, it's got a ways to go. It's going to get there, I know that, I'm sure of that. But it is 5 years, maybe 7 years out before it really has a value proposition associated with it, at least in my view. Third, here is capacity and culture, and capacity and culture are extremely important. This is about having the people, the tools, and the skills to make the most of the opportunities created by new and emerging information sources. Capacity and culture are probably the two biggest issues facing the effective use of data in healthcare, be it big data analytics or be it health system use or whatever you want to classify. Quite frankly, out there, there isn't a culture of using data effectively. There isn't a culture of measurement, there isn't a culture of data sharing and use, and there isn't really a culture of continuous improvement to advance care and healthcare system performance. There is in some institutions, it is getting better, don't get me wrong, but the culture isn't all that strong. Secondly, the capacity isn't really there either. Not everyone has to be an analytical expert, but general health information literary skills are required to ask the right questions, understand the answers, and to be able to act on the information gleaned from the data. Unfortunately, information literacy skills are in short supply in this country. Interestingly, I was just reading last week that the UK government recognized that problem and announced over $30 million Canadian dollars to assist 15 UK universities to overhaul their social science teaching so as to, quote, address the critical shortage of social scientists with the quantitative skills needed to evaluate evidence and analyze data, unquote. This is a really big issue out there. We can produce all the data in the world and make it wonderfully visual and exciting and dynamic and so on, but if people don't understand it, it's a problem, and a lot of folks don't. At CIHI, we're trying to expand our capacity building tools and initiatives to help address this shortfall. We have a lot more face-to-face and data user conferences. We're looking at data schools. We have one coming up in the Atlantic provinces where people will just be able to take a look at our data and learn from it. We have an activity-based funding school that will probably in the spring be putting up, and we have some great guest speakers coming and so on. But quite frankly, a lot more needs to be done around capacity and culture. Let me move on here. Data evolution. It's a fantastic thing. In the past decade, there's really been a significant evolution around the availability and use of data in the Canadian healthcare system, and this is really a great thing. The 2000, 2003, and 2004 health accords really at their core had transparency and accountability about them, okay? And building off of that, what's gone on in the provinces. We've seen quite a few new health quality councils. So I believe we have 7 now across the country. Back in 2004, we had 3. CIHI received significant injections of federal funding, which was very important. And really, this has resulted in an explosion in the data and the availability of data. We've gone from 18 databases in the year 2000 to about 28 databases today. And we're taking the databases out of their silos, where they're individualized, and we look at them individually, and we're beginning to integrate them more and more and more. The implementation of the EHR across the country is slowly bringing new sources of digital data in real time to facilities and clinicians. I think very importantly of, again, the Humber River exercise here in Ontario and the mainland Cerner project, the $800 million project to bring the EHR in a major way into the healthcare systems in BC as being very, very rich in data. And we are watching carefully and working with the folks to see what it is that we can, at CIHI, can extract in terms of that data and how we can turn it around into knowledge, and knowledge useful for the clinicians, knowledge useful for the system managers and others out there. The EMR, again, is a different story, as I've said. It's unstructured and uncoded data. And while there has been significant penetration of the EMR across the country, and again, this is a very good thing, but as long as physicians tend to use it for billing, note-taking, and filing, I think the real potential of the electronic medical record in Canada is just going to go unrealized. Again, it's going to take the will of physicians, it's going to take the will of governments and others. It's a step up to the plate to adopt the standards and make it a requirement that physicians report the data back. They're doing it in the US, they're doing it elsewhere. In Canada, hopefully, we will get there. You know, sensors are out there. What is it? The magic carpet, which can detect falls in homes. Sensors will be used in homes. Sensors will be used more and more in the hospital as well. And there's going to be a lot of data flowing from there. There already is data flowing from an awful lot of sensors that are out there. And personalized medicine, if you believe in it, not everybody does, but if you believe in it, that's going to be another huge source of very rich data with the genome being mapped and so on from there. You know, 23andMe, if you haven't been on the website, it's sort of fun, you know? You can go out and you can find out, you know, a little bit about yourself and scare yourself endlessly and find out you have all these new diseases you'd never heard of before, and you can sit around and worry about your health care forever as a result of that. But the cost of mapping the genome has come down tremendously. I think 23andMe is about $300 so far. And when they get it down to that $20, that $50 range, there's value. There's a value proposition out there, okay? So it should be exciting, and I really do, I do see by 2020 an awful lot of promise out there. Let me talk about my favorite area, which is really the analysis revolution, okay? As an economist, I love analytics. I love econometrics. I love all these things. Now, I've forgotten an awful lot. In fact, my staff would say I've forgotten everything that I learned at school, which is sort of true. I can fake it occasionally, eh? But yesterday, way back when, in the year 2000 and before, what were we looking at? Basic statistical analysis, okay? Basic forecasting out there, some basic labor models being developed, queuing theory. I remember, I won't mention Ben Chan, who some of you may know, but I remember back in, 2004, Ben and I having a chat. Ben used to be here, the CEO of the Health Quality Council, Health Quality Ontario, but he was also the CEO out in Saskatchewan, where I was, of the Health Quality Council out there, talking to me about queuing theory and how exciting it was. And I'm going, Ben, I took that back in 1975 at university. Healthcare, slow to take up things, slow to take up technologies, right? Slow to take up analytical techniques. But I think in Canada, we are beginning to take them up, okay? Today, in the world of analytics, what are we looking at? We're looking at pretty advanced tools. At Keynote, we risk adjust our indicators in a number of ways. The staff call it a great science. Some of us call it a great art. But the econometrics used to risk adjust things is phenomenal. We do it with hospital standardized mortality ratio, which is a very big dot indicator, very important indicator, and a lot of what we call the inter-eye quality indicators as well. More and more jurisdictions out there are adopting activity-based funding as a way of pushing dollars out to facilities and to regional health authorities and so on. And at Keynote, you've got to make sure that your data is really, really clean for activity-based funding. And so what we're looking at is fraud detection. And that's fraud detection frameworks and models have made tremendous progress over the last few years. And that will simply ensure that a facility's data, the integrity of a facility's data. We're also looking at something called this PRAG down at the NPRAG. It's a population risk-adjusted grouper. It's another means of funding formulas that actually integrates a tremendous number of databases that are out there to describe a population's healthcare characteristics and to be able to predict what it will look like 5 years out, 10 years out, and so on, okay? It'll take us a while to get there, but the PRAG is really important. The other one, HARP here, is something that from the analytical side I think is really exciting, and we've been working with Health Quality Ontario on developing a means of identifying people who are at risk of hospitalization. We've developed with them a patient risk score, and this has been really, really good. It's basically, again, econometrics with some statistical techniques, throw in an algorithm or two, and you can tell, given a person's certain characteristics, health utilization patterns, and so on, at what risk they will be to be readmitted. So, the analytical world has really, really developed quite nicely. When we think of the future, again, artificial intelligence and what's going on in the world of math around that, machine learning, it's phenomenal. Neural networks and the way in which that can be utilized, all subsets of artificial intelligence, very, very, very fascinating, and I think hold great promise as well for healthcare here in Canada. Natural language processing, as I mentioned, I think is going to be front and center. And there's all sorts of new analytical tools out there, swarm analysis, which is deals with how ants behave and so on. But I think it does have some value as we move forward into the future. There's also a reporting transformation, which is very exciting. Yesterday, basic PowerPoint, right? That was the bread and butter of things. You make a presentation in my world to cabinet ministers or cabinet, you'd have basic PowerPoint, eh? Basic statistical displays, basic tables, everything was pretty plain, and there was no such thing as social media. I think, what was it, back in 2000, Google was 4 years old at that point in time? Facebook didn't exist. I've never been on Facebook. I don't know how to Twitter. I don't know how to tweet. I've never sent a text message, and oddly enough, I don't even own a cell phone. So I don't know much about social media, but I hear it's a great thing, okay? Today, it's wonderful. The infographics and the graphics that David was displaying, the pictures, all of this stuff is really, really exciting. Social media and the information that's there, It's so quick that apparently, you know, you can get your message out there, and I say apparently because I don't really know, but my communications people tell me, okay, we've got a Twitter group that's following us, okay, and we can get our messaging out in a big way, okay? Mobile platforms are phenomenal out there. You guys know more about this than I ever will. But the visualization software is just wonderful. And at Keyhigh, what we're doing is we're actually moving more and more into that world of infographics, both static and dynamic. We are finding that people out there, the public, really like that. They find it much easier to understand. And this may sound odd, but so do deputy ministers of health, okay? They're not all necessarily strong in their mathematical backgrounds. In fact, none of them are. I didn't say that, did I? Again, I used to be a deputy of health, so I can probably get away with that, but they're not. They've got too much time, not enough time on their hands, sorry. And boy, I'm having a lot of slips today, eh? That's okay. But they don't have time on their hands, and simply infographics can display things and bring it to, you know, just right there, right in front of you, and you know what's going on immediately, eh? And that long statistical boring table is gone, and it's really, really important, okay? Tomorrow, I think it's going to be equally as interesting. Holographic, dynamic holographic displays, I think they say they're not far off, and I think that that's going to be an absolutely fascinating way of displaying data and displaying information. Okay, I'm not quite sure what augmented reality is. Sounds interesting. I didn't inhale. Natural language questioning and answering, I think, will be a reality, and that'll be very, very important as we move forward. So have I got some, just to show you some, we have a website coming up November the 7th, and this is just some of the infographics that we're going to be using. It's for the public. And it's really quite simple, really quite straightforward, and takes an awful lot of information and really simplifies it. Some simple advice, okay? And advice, they say, is cheap. But some simple advice. In my perfect world, and it's only my perfect world, free text would be banned, okay? We really need to have it structured and to have it coded to make it worthwhile. Look, if you can't measure it, you can't manage it. And what you can't compare, if it's not standardized, you can't compare. I was just reading something from 1964, Justice Emmett Hall, who on the National Task Force on Healthcare, which laid the groundwork for our healthcare system today, was commenting about the importance of statistics and how important it is to be able to compare. And that's why I say I got a problem with free text. Focus, 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 focus. You know, we used to have accountability agreements back in Saskatchewan when I was the deputy with our regional health authorities, and we had over 200 pieces of data and targets. And so this was madness, 200. How can you, this is craziness, okay? Focus on what's important. There's just too much information going out there, and you can't, as a senior policymaker or as a clinician or others, you just can't deal with it. Focus on a select number of quality, actionable data to get the message across, okay? And real value is extremely important. Make the proposition clear to your clients, okay? Be it on the vendor side, the consultancy side, and tell the physicians, tell the clinicians what is in there for them and their patients, okay? That's really, really important. Get down and make sure that they have a clear understanding of this. Finally, make it easy, okay? People out there aren't IT experts. They're not mathematicians. Watch yourself with the jargon around there. And I say that because, you know, for some people, it really sets them off, okay? If you can use plain language, great. I understand that in Canada, or not in Canada, in the world, there's something like 500,000 a category of words. 500,000 English words. It's the richest language in the world. Let's try to use the 500,000 instead of developing new words to explain things, okay? You know. Keep it easy. Keep it simple, okay? You know, I don't know what all these buttons are for on my TV thing. I don't know. I use 3 or 4 of them. This is a picture of mine wrapped up, okay? But it makes a lot of sense, okay? So, let me try to tell you about some near-term opportunities, and very much like what David's saying. With the clinicians, I think that that's where your focal point will be. I say pilot projects because that's what you need to do right now. You need to be able to demonstrate and to learn from the governance issues, the privacy issues, the integration issues. We all need to learn more. Consultancy community, the vendor community, governments need more, policymakers, everybody needs to. And so pilot projects, I think, in the near term are the way to go. Your natural partners are the clinicians within the academic health science centers here in Canada. With all due respect to Prince Albert and the Regional Health Authority up there, or Interior Health in BC, or the facility up in Wawa, they don't have the skill set, they don't have the capacity, okay? The academic health science centers do. They have the universities associated with them. That's a natural place to go. In terms of the analytics, I think there's great opportunity here, I really do. I think the ministries can learn an awful lot more. I know a lot of you are in talking with folks, and I think that that's tremendous as well. Predictive modeling for labor, predictive modeling for optimal or peak pricing or peak loading, workforce management. There's just a tremendous number of opportunities there. Again, fraud detection, particularly for BC, Alberta, and Ontario, as it goes through activity-based funding. We're looking at fraud detection models. Those ministries may be wanting to learn more as well about frameworks and about the models themselves. And finally, reporting. Reporting should be appealing to everybody out there, okay? The software, as I understand it, is pretty straightforward. If you can't get into a ministry, give the minister a call or send them a picture, because ministers love pictures, okay? They understand it, and they know then that their citizens will understand it as well. And anything that a minister can do to get the message out, I think is a phenomenal thing. And I think infographics and some of the new data visualization techniques are wonderful as well. So let me try to wrap up here, and then I think I'm going to take a few questions. So at this point, I want to give you a quote here. And this quote is actually from the future. And it's from Captain James T. Kirk looking back at the 21st century. And when he was looking at big data analytics, he said of it in the 21st century, it was a dream that became a reality and spread throughout the stars. So thank you very much. Great.